A very good day, my dear postgraduate students. We shall go to our third class on bone marrow aspiration. And the theme is hypercellularity. In the background, I am finding the bone marrow flooded with cells, thanks to American Society of Hematology for this wonderful, knowledgeable picture. And my dear students, again, it took me 2 years to identify the bone marrow cells as a postgraduate student. If today I can do this with ease, the credit goes to late Professor Dr. Sethuraman of Madras Medical College. He was in fact the 4th unit medicine chief who taught me the cells. He has had a self-inclined interest towards the leukemia clinic. This we had already seen. It is for a recapitulation. The pictures are from my book, one page. The Sala and the Klima needle, the lateral adjustable guard, and the Jamshidi needle. Remember, the needles are all short, stout, and they have got a stillet. My goodness. How am I to approach a complex topic like this or a table like this? Always, when in doubt, delegate or divide. This is regarding the handling of a bone marrow biopsy or aspiration. I told you, divide or delegate. Let us see. First, look at the fixatives. It can be buffered formalin, bovine solution, or sometimes B5 is being used, Schaffers and buffered formalin or zinc formalin. Many things are there. You people can just go see how to read a table like this. The second one will be decalcification. It can be because of EDTA or formic acid, nitric acid, etc. Embedding. It can be simply paraffin embedding or plastic embedding. And the uses can be immunohistochemistry, fish, PCR, etc. And finally, there can be the other methods such as the microwave, ultrasound, etc. Sometimes combined fixatives and decalcifying agents can also be used. This is the way you people can make a complex table easy. At a time, by heart only. Assessing the cellularity. As I told you people, you will have to follow the bone marrow particles and the cell trials, not the diluted cells that you find along with the peripheral. And always the dictum is normal is equal to 100 minus the age of the patient. For example, the patient is a 1-year-old child. It has to be almost 100% cell. If it is going to be a 40-year-old male, then it can be 60% or plus. And 4 lineages will have to be identified. It can be the erythroid, myeloid, megakaryocytic, and the lymphocytic and plasmacytic. Identification of the cells matters most. And as I had been telling you people, differential count is the only tool to learn the cells. I am not going to go into it, but then there is a plethora of it. Your slides under your microscope will be able to give a much better refractive index than this. So I'm able to see the neutrophilic series, and then probably, as I told you, maybe these are the lymphoid or the erythroid cells. Identify a cell by the company it keeps. But what I should appreciate it is a highly cellular marrow. A hypercellular marrow can occur in these following conditions. 1. Infants and young children, more than 90% almost. Reaction to a peripheral decrease. Any case of a pancytopenia, there may be a reactive marrow, or there has been a suppression with pancytopenia, and along with that there is a response to treatment. So you will have to rule out a history of hematinics. There can be erythropoiesis, leukopoiesis, megakaryopoiesis. All may or may not be active together. Withdrawal of the suppressing factor. As I had been telling you in another example, the patient has been under an exposure to the chemicals. There is an aplasia and he is dissuaded from it. And you find that the bone marrow starts recovering. Infiltration, this is by cells which are foreign to the marrow. It can be any of the metastases or it can be lymphoma or whatsoever. So these are some conditions where you can get a hypercellular marrow. Always a history will be essential. The patient's or the relative's narration. Infection. It is not uncommon for us. No, we have had the COVID swell and all. And almost every other case was a case of a leukopenia and a thrombocytopenia. Pathology became very important in those days. History of drug intake. Phenytoin sodium, for example, is supposed to cause an aplasia. Any of the chemotherapeutic drugs, again, there can be a pancytopenia and an aplasia. Antibiotics, chemotherapy, anticonvulsant drugs, occupation, radiation, exposure to chemicals, so on and so forth. The complications can sometimes be hematoma, infections, and in an aspiration, no, we will have to take care of these things. I have not told you this earlier. Whenever you do a bone marrow aspiration, it can subsequently lead to a hematoma. There may be infections, but it is highly unlikely when we follow the sterile precautions. Damage to the underlying structures, particularly manubrium sterni, we have got the aorta of the heart. And bleeding, of course. Dry tap. It is not uncommon. Dry tap by itself, it can happen in a number of conditions, including aplasia as well as hyperplasia. I shall be dealing with it on a different class. And differential count. Why at all should you people count the cells? There are different reasons for it. One, for obtaining the ratio, the different kinds of cells. And when you do a differential count only, you will be identifying the cell. Supposing I see this cell, I call it a particular name, and then I click the button, that means I'm committing. Therefore, I'm learning something. To judge the distribution, as I told you, the cells keep a group. Identify the cell by the company it keeps. To identify the other cells also. For example, there may be some cells which are foreign, storage cells, immature counterpart of the normal cells, increased in the mitosis. There is a cell division that is over here, atypical mitosis. So all this, you will not be looking for it, but as you count over 500 cells, automatically they will be coming across your eyes, you will be picking them up. A normal differential count, you people should know. I would like you to go to any standard text. This is in fact from my book, one page, wherein I have a rough idea about the differential count in an adult of the bone marrow cells. This is again, we had already seen the sites for a bone marrow aspiration. Always mention anterior superior iliac spine, posterior superior iliac spine, manubrium sterni, tibial tuberosity, and vertebral spine. It will be better that you people are very specific in your mentioning. And this again, we have already covered the methods of making a spear. So I'm finding a squash preparation, the bone marrow particles are there along with the cell trial. This is a wedge preparation, wherein there is the cell trail that is created from the marrow particles. And the procedures you people already know. Express. Whenever there is an aspirate, you express it. Then using another needle and syringe, you siphon off so that only the cellular marrow particles are left behind. You may use either a squash preparation or the marrow particles and a smear. Then finally you do the staining. So sometimes no, you find that expression matters. That is why I had mentioned it over here. The Christopher's expression, a beautiful picture. That is off the track, but then quite innovative. The cells we people should be knowing. This is one, a stem cell, and then there is a committed stem cell. There is a myeloid one, wherein you get the myeloid series, and then sometimes granulocytic, erythroid, and monocytic series, megakaryocytic series can be together. Therefore, there can be an erythroid also coming out of it as well as the megakaryocyte. Finally, you find that the lymphoid cells are totally different. That is why you find that the lymphocytes and the plasma cells will be unaffected in the case of aplastic anemia. The erythroid maturation. So this is again from my book, the one page. So I find that there is a pro-erythroblast, a basophilic erythroblast, polychromatic, orthochromatic, and finally the mature erythrocyte. So in this case, progressively there is a reduction in the size of both the cytoplasm and the nucleus, and there is a maturation, condensation, and finally the expression. Remnants can be seen in a reticulin stain. So the granulopoiesis on the contrary. You are supposed to judge the size of the nucleus, granules. Look at this. I would like to take some time to teach you people what it is. So this is a hematocytoblast. It is not different from the other cells, but we see it very rarely. Then there is a common progenitor myelo cell. So this can sometimes lead to a leukemia. You find something like an undifferentiated leukemia. Let us forget that. After this, we have got the series of the neutrophilic cells. So as a myeloblast, then a promyelocyte, myelocyte, metamyelocyte, a stab form, and then the matures. In this one, it can be either granular or agranular, the myeloblast. Usually I say it is agranular. It has got a large nucleus, prominent nucleoli, 2 to 5 in number. After this one, there is the promyelocyte. There will be some kind of granules which are appearing in the cytoplasm. Nucleoli are present, but they become more faded. In fact, when compared with the myeloblast, the promyelocyte is slightly larger. There will be granules in the cytoplasm, which are called primary granules. From this stage onwards, all the cells will be having granules. Then they become more committed. From the myelocyte downwards, you find that they are committed one. Therefore, you can have a neutrophilic myelocyte, eosinophilic myelocyte, basophilic myelocyte, metamyelocyte, stab form, and the matures. So this is extremely important courtesy at upstop for us to have a concept of this particular one. So look at this. Obviously, it is 100% cellularity that is over here. And there are two things that we will have to. One, it is a suppression. I cannot see the cells or identify them. That doesn't matter at all. Why is the marrow so cellular? One, there has been a suppression and then a recovery. Or two, the patient is on hematinics. Or three, there has been an infiltration. It can be a lymphoma, it can be a leukemia, it can be a metastasis, whatsoever. But this amount of cellularity is definitely not very good. So this is again an explanation of the bone marrow aspiration. I would like you people to kindly appreciate the lateral apertures over here. And then there is a central core. Because of the lateral apertures, as soon as the needle is inside, you find that the dilute particle or the component of it comes in as a aspirate, whereas the cutting needle takes the biopsy tissue without disturbing this. So there is a cortical bone, and then there is a spongy bone, there is a marrow over here. Thanks to this, Anwarul Islam for the beautiful picture, and probably he would have been a research scientist or a PhD scholar. What are your comments on this? So there is obviously cellularity, but I am not finding the conventional cells of the marrow. They are something totally different, and all of these are looking almost like a lymph node to me. Yes, it is a case of a lymph node. And this is a mitosis. In mitosis, the cell membrane will be there, but the nuclear membrane will not be seen. And you find that it blooms like a flower. There can be a prophase where it is arranged along the equator. Then there is a metaphase wherein there is a slight separation of it. That is exactly what we are seeing. Then finally there can be a anaphase and then a telophase. So this is what is happening. Now this is a conventional one. Sometimes as I told you or will be telling you in another slide, there can be a tripolar mitosis or an atypical mitosis, which means there is an abnormal response or a dyserythropoiesis, dyshematopoiesis that is happening. And now, what are the causes of a hypercellular marrow? I would like you people to kindly recall.